please enjoy the lecture. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Prof. Badrul Hikar, for the very nice opening. And now we would like to go to the main session of today's meetings. So Professor Khalili would give a presentation. So before giving his presentation, I would like to read a bit of his CV. Associate Professor Dafud Khalili is Associate Professor of Prevention of Metabolic Disorders Research Center, Research Institute for Endocrine Science, Shahid Beheshti, University of Medical Science, Tehran, Iran. He also holds a position in the Lone Scholar in Cardiovascular Health, Harvard T.H. Chan School of Public Health. He's also the Secretary General of Iron Cohort of Consortium, as well as the Director of Department of Biostatistics and Epidemiology, Research Institute for Endocrine Science, Shahid Beheshti, University of Medical Science, Tehran, Iran. So he had a lot of experience developing prediction model on a global level, the global risk factors, as well as at national level. So he will give his lecture on implementing appropriate national CVD risk prediction models for clinical and public use. Please, Dr. Khalili, time is yours.
Thank you so much. Thanks to Professor Harbuno and Professor Higar for their nice opening. And thanks to Dr. Diki for introducing me. I'm so happy that I'm here with you for this lecture, for this issue, actually. And many thanks for having me as a guest lecturer here. Well, we are going to talk we are going to talk a little bit about the prediction, but not as ancient magicians, but scientifically. As a disclosure, I've received funding for some lectures from some local drug companies in Iran. I'm co-author of the Global Risk Equation for Cardiovascular Diseases, and I'm co-author of the WHO revised model for cardiovascular diseases. And it's the talk outline. We are going to talk about the burden of cardiovascular diseases in Indonesia versus other parts of the world, and the importance of cardiovascular prediction models that named equations or risk chart with different names. In this lecture, we may name equations or risk chart or prediction models. And then regarding, we are talking about concept of the equation and its recalibration for new populations and new countries. And we talk about some well-known CVD prediction models, and finally, some considerations for using the prediction models. As Professor Harbuno and Higar said, cardiovascular disease remained a worldwide leading cause of mortality and morbidity, despite the huge effort in improving clinical outcomes in recent decades. Based on the Global Burden Disease GBD project that's did in IHME Institute in US, we can see a decreasing trend in CVD mortality in developed countries and even in some developing countries, but a plateau institute in Indonesia. And here is the trend of non-HDL cholesterol during last decades in Indonesia versus the world. And as you can see, the trend for Indonesia is increasing. The dotted line is represent the global trend, but the solid lines is the trend in Indonesia. So policymakers in Indonesia should do something for prevention and control of CVD and its risk factors, and maybe using clinical prediction models is a way for this issue. As you know, the ability to assess individual risk for future CVD events is the crux of preventive cardiology. It's a puzzle, actually. for identifying high-risk individuals and thereby reduce the risk through appropriate interventions in different levels. Total CVD risk expresses the combined effect of a number of CVD risk factors. You know that cardiovascular disease is a multifactorial disease, not a single factor disease. And rationale for using a risk estimation is that the CVD is a multifactorial disease, and a combination of several seemingly modest factors may result in much higher total risk than a single more impressive neuralized factor. I mean, a person with the modest risk factors may have a higher risk than a person with just one risk factors. For this reason, we use prediction models to get together all risk factors together to one number and make decision for patients using this number. Well, all current guidelines on prevention cardiovascular disease usually introduce some risk scores. And the higher the risk, the more intense of interventions should do. For many risk assessment systems are available, and most guidelines use one of these risk scores. For example, WHO risk score, from income risk score, a score in Europe, and also global risk and so on. Okay, prediction models support informed treatment decision about the initiation or adjustment of preventive interventions or medications, and risk prediction models facilitate risk communication to patients. Actually, traditional physicians usually estimate prognosis by their own actually clinical judgment, but prediction models can help to estimate an objective risk and an unbiased and reliable tools as an alternative to clinical judgment, to apply risk prediction tools from multivariate algorithm in which relative weights are assigned to each predictor in order to calculate the likelihood of a specific outcome or a specific time. You know that different risk factors have different effect on cardiovascular diseases, and using prediction models, we can calculate the overall risk using these weights to pull together all risk factors and calculate a risk and communicate with patients with this risk and decide about the future interventions for patients with her or his health. Ideally, risk equations should be based on cohort studies in a community, and it needs population-based cohort studies. But population-based cohort studies are not available for most countries. We should have a cohort, a general population, and measure their risk factors, their exposures, and follow them during the time, and up to an event happened for some of individuals. And then based on this data, we can develop a risk score. But fortunately, risk scoring system can be recalibrated for use in different population by adjusting for incidence of CVD and distribution of risk factors in that population. What does it mean? What does it mean that we can recalibrate a prediction model for a population? Okay. Okay. Risk charts and risk assessment system are simplified risk equations, actually. Risk charts come from complicated risk equations. And risk equations calculate the probability of an event, here cardiovascular disease, usually using an equation like this. It's a general concept of a prediction model. P is the probability of the disease, here cardiovascular disease. ST is baseline survival in a population, baseline survival for cardiovascular events, and a linear predictor. Linear predictor here consists of some factors, beta coefficients, X, and mean of risk factors. So an equation have three main parts. ST, baseline survival in community. M is mean of risk factors in the community. And beta coefficient, that is effect of risk factors on CVD. So we can recalibrate the equation using local information of a specific population. We can replace some statistics in this equation with local factors, with local characteristics. Beta coefficients in each equation considered a fixed factor that is usually fixed in all the world, because usually risk factors do the same everywhere in the world. For example, the smoking double the risk of cardiovascular disease, and this risk ratio is the same everywhere in the world. But ST and mean of risk factors, M, is different in different populations. So in a prediction model developed in a cohort study, in a large population-based cohort study, can be recalibrated for each population, but by replacing ST and M from characteristic and information from that population. ST is baseline survival in the community, and for example, is based on annual CVD mortality or annual CVD incidence in a country. That is, especially CVD mortality rate is clear in each country, and we can use that. And M is mean of risk factors in the community. For example, risk factors usually can be measured in a survey, in the national surveys in a country, and we can use national surveys for NCD risk factor to calculate the mean of risk factors in that community. The first cardiovascular disease come from income study 2 or 3 decades ago. And after that, this risk score updated with a new one that considered both coronary heart disease and a stroke. For the first time, the from income risk score recalibrated for Chinese population. And as I said, they replaced the baseline survival and mean of risk factors in the original model of from income and recalibrated this model for Chinese population. And it's here the original model and the recalibrated model. Here you can see the columns that related to original rate, I mean the probability of CHD events in population, and compared with the predicted ones. Here you can see the deciles of the predicted risk, and in each decile you can see the mean of predicted risk versus the real rate in that decile. As you can see here, using original model, overestimated the risk in Chinese population. These tall columns is a kind of overestimation for CVD risk in Chinese population. But after recalibration here, below graphs, we can see that after recalibration, the observed risk is compatible with the predicted risk in different deciles. Then we recalibrated the from-income risk score for Iranian population and showed that using original model and recalibrated model did not differ, and both of them has a modest compatibility with the predicted risk. I mean, the observed risk and predicted risk was the same both in original model and in recalibrated model. Then we found that we can use from-income risk score without recalibration for Iranian population. It's because we have the same risk and risk factors in Iran and US, actually. Since from-income risk score was based on just a local population, I mean from-income, a population from-income city in Massachusetts, US scientists decided to develop develop and validate a new risk score which is more representative for US population. So the AHA, American Heart Association, and American College of Cardiology used a pooled cohort equation, and they introduced this model that developed in 4 large population cohort studies in US. ERIC cohort, CHS cohort, Cardia, and also from-income, original from-income and offspring from-income cohort studies. Unlike the from-income score, risk score, this risk score that used the new cohorts in US focused on estimating both risk of CHD and stroke, and additionally provided sex and race-specific tools for US population. So the generalizability of the risk score improved, and they could use this risk score for other populations in US, especially Black populations there. Here is a list of well-known cardiovascular risk prediction models from income, score in Europe, assign and Q-risk in US, in UK, and PROCOM in Germany, Reynolds risk score in US, Cure in Italy, and pooled cohort equation that I said from US, and global risk that used 8 cohort studies in United States. Actually, all of these risk scores, except the from income, are for cardiovascular disease events, and some of them, like score, is for CVD mortality. Global risk is for both CVD mortality and CVD instances, total CVD, I mean. And all of them uses traditional risk factors, as you can see here: age, gender, total cholesterol, HDL cholesterol, diabetes, smoking, blood pressure, hypertension treatment, and so on. There is a debate about the optimum algorithm for cardiovascular disease. Which risk score is the best? Here is a head-to-head comparison of 4 algorithms recommended by primary prevention guidelines. You can see they're actually concordance before and after recalibration. The first line, above line, is for before recalibration, and after recalibration for a unique population. After recalibration for a unique population and with the same CVD outcomes, we can see that they are so compatible. For example, based on the FRS from income risk score and score from Europe, FRS from US, more than 75% of high-risk people that identified by the risk score are the same. And the compatibility here is 84% and 80% for Reynolds risk score and score risk equations. Okay, a CVD risk equation should work as a valid test to identify high-risk individuals, you know. The overestimation of patients may imply unnecessary medication and induce some side effects, as well as financial burden, whereas underestimation may imply a higher risk of event occurrence, actually. So we need to calculate the sensitivity, specificity, and net benefit of a risk prediction model as a clinical test. So health care providers can get easily confused by the wide range of available risk algorithms, and they should think that which one is valid for their population. Well, the global risk equation is the first cardiovascular disease risk score that predicts risk of heart attack or a stroke in healthy individuals for all countries in the world. They could recalibrate a risk score that developed in US using 8 large population cohort studies in US and recalibrate this risk equation, this risk score for every country in the world using the local information from that countries. For example, regarding using CVD mortality rates from WHO estimations and mean of risk factors that's calculated for each country using NCD risk group in Imperial College London University. So this risk score has been recalibrated for all countries based on their own population characteristics. WHO did the same during a couple of years later and do the same and developed a risk score, actually updated its previous risk score and adapted it to the 21 global regions. Adaptation to circumstances of 21 global regions means recalibration for that regions. WHO used information, local information for different regions, and using that information, I mean CVD incidence or CVD mortality for that region, and mean of risk factors from that regions to adapt the risk score for those regions. As you can see, WHO has 2 kinds of prediction models, laboratory-based models and non-laboratory-based models. It's because WHO think about remote areas and areas that have not enough facilities for some measurements like total cholesterol or HDL cholesterol or even fasting plasma glucose for everyone for remote areas. So they introduce no laboratory-based models that can be used for everyone and can be used as a self-assessment without any actually expensive measurements. Here in laboratory-based models, you can see that there is some lab measurements, for example, plasma glucose for defining diabetes and total cholesterol. But in non-laboratory-based models, BMI replaced instead of history of diabetes and total cholesterol. It's risk chart for Indonesia, non-laboratory based risk chart for Indonesia, and it's a lab-based risk chart. As I said, these risk charts come from that risk equations I showed that includes 3 parts, including baseline survival, beta coefficients, and mean of risk factors. And they simplified that complex equation to these simple risk charts. So this risk charts uses some simple and available unconventional risk factors like age, sex, diabetes, systolic blood pressure, and total cholesterol. The question here is, do the other clinical measures have added value to the conventional risk factors? The response is that we are not sure. But among serum biomarkers, genetic factors, and imaging indicators, just coronary artery calcium showed a highly specific marker for coronary atherosclerosis. CAC scoring has emerged as a consistent and reproducible means of assessing risk of major CVD outcomes, especially for using in asymptomatic patients for primary prevention interventions, and can be used for prescribing statin and aspirin for primary prevention. However, it's just widely available in developed countries and is not recommended for developing countries. It cannot be used for general population in developing countries because it's so expensive and cannot be used as a simple and cheap measurement tools for public health. Just maybe for some clinical uses, for some special cases that patient can, that doctor or physician cannot make a decision using conventional risk factors. Well, an important issue for using risk scoring is risk threshold or risk cutoff or cutoff point. To classify individuals based on their risk, we need some sensitive and specific risk thresholds. The question is that in which risk threshold does the benefit of an intervention like statin therapy outweigh its harm? Its harm means its side effects or cost. And in which risk threshold do people prefer to be treated with regards to the benefit of treatment, means prevention or prevention of events, and its cumbersome usage, means side effects, its cost, and taking medicine is not easy for everyone, because every day you should take a medicine and don't forget that, and so on. For example, ATP3 guideline used a risk threshold of 20% for prescribing statin in high-risk people for CVD. But after that, in American Heart Association and American College of Cardiology guidelines, this risk threshold changed to 7.5%. And many experts said that it's kind of medicalization, it's not safe to give everyone with this risk threshold, to give everyone a statin, and so on. And it was controversy for changing this threshold from 20% to 7.5%. In Heart's technical package, which is a package for developing countries developed by WHO, this Heart technical package have 7 or 8 modules. One of these modules is risk-based CVD management. In this module, the risk in different risk thresholds, healthcare providers should do different interventions. For example, in risks lower than 10%, just a consultation is okay. Consultation for diet, physical activity, and smoking cessation. And if the risk is lower than 5%, healthcare providers can follow that individual 12 months later. When risk is between 5 and 10%, they should follow that individual every 3 months. But if the risk is between 10 to 20%, besides the consultation for diet, physical activity, and smoking, they should control his or her blood pressure strictly and follow that person every 3 to 6 months. And when the risk is above 20%, that individual should take a statin. The problem here is that for this risk threshold, just clinical expertise and research evidences have been used. But regarding the evidence-based medicine trial, we need patient value as well. It's an ignored point for using risk scoring in the world. For this reason, we developed, we did research regarding clinical usefulness of risk-based prevention in primary healthcare setting in rural and urban areas in Iran, because rural and urban areas has different characteristics, different risk factors, different facilities actually, and named this project prediction, because from prediction to action for any required intervention. This project supported by Harvard T.H. School of Public Health in the Loan Scholarship program. It's the first publication of this project that determined Iranian general population and healthcare providers' preferences for benefits and harm of statin therapy for primary prevention of cardiovascular diseases. In this project, we conducted a preference eliciting survey incorporating a best-worst scaling instrument. We considered 13 outcomes related to statin, events that statin can prevent them, and outcomes and events that statin can induce them. From moderate MI, severe MI, to diabetes, acute kidney failure, cancer, or nausea and headache as a side effects of statin. And the relative importance of these 13 statin-related outcomes was assessed on a sample of more than 1,000 participants, including both general population and healthcare providers. And we asked them to rank these outcomes using these actually sets. In these 13 outcomes divided to actually different sets, and they compared together 2 by 2, and we asked them that select the best or the most worrisome and the least worrisome outcome in their point of view. For example, they should select among liver injury, muscle pain, cancer, and sugar disease or diabetes, the most worrisome and the least worrisome. For example, someone can choose cancer as the most worrisome, but sugar disease or muscle pain as the least worrisome outcome. And after that, we ranked them, and using some complex statistics, we could calculate a weight for each of those outcomes. And here you can see that these ranks are the same between healthcare providers and general population. And also these ranks are the same, or somehow the same, between urban population and rural population. And this figure depicts the relative importance of the outcomes regarding the mean score of each outcome, and also the standard deviation. It means both mean and ST of each outcome based on the individual's preferences. For example, here you can see that severe stroke has a high score as a worrisome outcome, and with a very low actually variance. I mean, many of individuals choose severe stroke as a most worrisome outcome. But for example, acute kidney failure or here muscle pain took a very low score and with somehow a modest variance among individuals. And finally, we used a benefit-harm balance model to determine risk threshold above which statins provide net benefit, considering some elements. People preferences that, as I showed you, based on those questionnaires, and different positive effects of statin, I mean relative risk of statin for CVD events, and also using relative risk of statin for side effects, different side effects. And finally, using probabilities of different outcomes, including the incidence of CVD or the incidence of side effects in a population. Gathering all of these data from meta-analyses, systematic reviews, or local informations, finally, we use the benefit-harm balance model that's introduced by Gale and its extension that developed by Yebo for the same reason. And it's the final results. Here you can see that Here is the risk thresholds from 1 to 40% in different ages. And based on our statistical analysis, we found that men in different ages prefer to use statin in risk scores between 18 and 24. And the benefit of statin based on their own people preferences and the risk ratio of statin for CVD events and also for side effects. Based on these data, the benefit of statin happen when the risk threshold is between 18 and 24. And for women, this risk threshold would be between 24 to 28. It's like it's very similar to the risk score, risk threshold that nowadays is used. Another important issue for using risk scoring is clinical usefulness of the models. What does it mean? The question is, does the model work in the risk thresholds which are preferred by the evidence-based trial? I mean, in the risk threshold that we actually could calculate based on the benefit and harm of statin and patient preferences. If we use that risk thresholds, the model works on that risk thresholds, and it means that decision based on the model as a screening test should be valid. And its net benefit should be better than treating all or treating none of individuals. Two extreme decisions, treating none or treating all of patients. And between these two extremes, we should decide based on the model. If the model works better than treating all and treating none in the thresholds that is good for our people and based on our physicians and patients' point of view, we should decide this model works or not. Okay, we did it for our population and determined the clinical usefulness of Framingham and also pooled equation and score, risk score, and global risk score, and found that these risk score can be used for our population. The discussion regarding this point is out of the scope of this presentation, and I hope to discuss this point in future, actually. Thank you very much for your kind attention, and I'm ready for any question.
Thank you, Dr. Halili, for the very detailed and interesting presentations about the few important things about how to develop a prediction model and how the implementation in clinical and public health setting. So we are open for questions. So if your audience have some question, you can just either raise your hand, or you can also as well write your question on the question and answer on the chat box. On the chat box below. You can as well. Meanwhile, while we're waiting for the questions, I have some questions. About the prediction model. Yeah. Regarding the different aspect of ethnicity, because you mentioned before, like the Framingham and as well as the United States also develop a different prediction model. In Indonesia, we have also a very diverse ethnicity. We have more than 300 ethnicities in Indonesia. How would you see that as to develop a national prediction model for a country with quite numbers of ethnicity?
Yeah, actually it's interesting. many different ethnicities in a country. If you have enough information regarding the mean of risk factors in different ethnicities and the incidence of cardiovascular disease, or maybe at least the incidence of CVD mortality, you can update the models for those ethnicities. But when the ethnicities are so, there is so diversity in the ethnicities, and there is little, little populations that have, for example, I don't know, less than 1 million in the country, the updating of CVD risk score is not so stable. You know, for updating a risk score, we need a stable statistics. We need a stable incidence and stable mean of risk factors. When we don't have a stable statistics, so we can consider all of those ethnicities together and use a risk score for all of them. For example, in US, the pooled equation cohort risk score used just for 2 or 3 ethnicities. But you know, there are many ethnicities in US, but they divided ethnicities just for major ethnicities, not minor ethnicities. It's okay? Could I respond your question?
Yeah. I think that's quite clear. Because yeah, sometimes we need those risk predictions, because, for example, for the treatment of dyslipidemia, we really need the data in terms of the prediction, right? How many percentage of CVD event in the future?
Yeah.
And while we're using the Framingham, for example, for Indonesia, when we saw the data that you presented in China, you see there's quite a huge discrepancy between the predicted and also the actual probability. And when then you need to recalibrate first, and you can then later on use it. So would you recommend that each country need to recalibrate the Framingham based on their own data?
Yeah. I think you should just, I don't know, divided your country to, I know, 4 or 5 regions, and update the risk charts and the risk score for those population. And it's not, there is no need to update the risk score for everyone, actually, because the extreme is to update a risk score for 1 person. But you need a population with enough number to calculate the risk score for that population.
Okay. Yeah, the problem with Indonesia, because there are also marriage and so on, right? So usually we saw mixed ethnicity as well, especially in we don't really see like a pure ethnicity and so on. So we have
you should combine the same populations together. Since I think the environmental risk factors have more effect on CVD incidence than ethnicity, you know, and because the environment is the same for most of people, then we estimate that you can use limited risk scores for your country, not many diverse risk scores for every ethnicity or for any region. You know, because I don't know, does the lifestyle is so different between different regions in the Indonesia?
Yeah, the lifestyle could be very different compared, for example, Jakarta and maybe Manado and Papua is already, Flores already different lifestyle and environment as well.
Yeah. Do you have enough information regarding the incidence and the mean of risk factors for every region?
Yeah, I think we do have the data from the basic health research in which the Ministry of Health perform every I think every 5 to 6 years. So we do have the data. So yeah, we should maybe try to adjust those based on the local, you mean the regional, right? The regional data.
Yeah, yeah. And you see that the WHO updated the risk score for just 21 region in the world, not for each country, you know, because in each region, people have the same lifestyle and the same level of risk factors and the same incidence of diseases. Although there are many ethnicities, but the environmental situation is the same. For example, you can maybe update a model for your urban area and one for your rural area.
Yeah.
Yeah. And before that, you should study the difference between risk factors and difference between incidences in different areas in your country. I'm not sure you have such data. For example, difference in incidence of CVD. Do you know that there is any difference regarding incidence of CVD in different areas in Indonesia?
Yeah, I think we do have the data. I think we can extract those data.
Yeah,
not sure about the incidence, but actually the prevalence should be there. Yeah. So the thing is about Indonesia, but the urban and rural is really a bit difficult to differentiate, right? Because, for example, compare Jakarta is urban, you compare like in a different city, it might be rural. But if you go to Flores, for example, Ende is already called urban, but if you compare that to Jakarta, nothing compared to Jakarta. So it's really difficult to which one should be called urban or rural, because the change of lifestyle is already also can be observed in rural area as well, with the increase of transportation as well as economy in the rural area. So we have one interesting question from Bramantya. He asked about, to develop a risk prediction model, how much data should we collect to give an adequate model?
Yeah. As a rule of thumb, for validating a model, you should have at least 1,000 people with at least 100 events for updating a model. It's a rule of thumb. But for developing a new model, you need much more population. At least for each risk, if you know the risk factors and the kind of relationship between risk factors and outcome, is there any linear association between the exposure and outcomes and so on? If you know the risk factors and you know the kind of relationship between the exposure and outcome, then you need at least 20 events or more than 20 events per actually risk factor. For example, if you want to develop a prediction model using 10 risk factors, or you want to test 10 risk factors in a prediction model and develop a prediction model using at least 10 risk factors, so you need more than 200 events. And 200 events for 10 years of follow-up means more than actually 10 follow-up of 2,000 people. It means following more than 2,000 people for 10 years of follow-up to catch at least 200 events. And it's so difficult, yeah, but it's at least the number of population, number of events. Sometimes you want to know the kind of relationship between the exposure and the outcome. And for this reason, you need more and more events. And for this reason, newly developed prediction models uses different cohort studies and put all cohorts together. For example, for developing WHO risk score, I think the Cambridge University used more than 100 cohort studies with more than 15 years of follow-up. And this kind of cohort studies usually are so expensive and are not feasible for developing countries. And I think it's not a good way to develop a new prediction model for a country. The best one is calibration of a prediction model based on local information. It's a rule, actually.
Okay, thank you, Dafud, for the very clear explanation. So last questions maybe, because we bit before schedule. Another question: does the prospective cohort is the ideal study to develop the prediction model? Is it possible to use retrospective cohort?
Yeah, we can use retrospective cohorts if we have enough information regarding the exposures and the outcomes. And also you can develop a risk score based on case control studies. But there is problems for using case control studies because you need many statistics from other parts of the country. For example, you should know the incidence of CVD from somewhere in the country and the mean of risk factors and so on. But the best one is using a population-based cohort studies. For example, for some diseases, for example, for developing a prediction model for diabetic patients, you can use registries, diabetic registries, and it's a kind of retrospective cohort studies. If you have enough information regarding the exposures and the outcome, yes, you can develop a prediction model using retrospective cohort studies.
Okay, maybe another last questions. You presented some prediction model, among which is the WHO 2019 that you presented, but you also involved in the global risk, and also there are other models as well. So which model would you recommend to be applied in certain country, for example, because they also use already improved by for every country, right, or country or region, right? So which one do you recommend?
Yeah, it's so difficult to answer this question because you should check different models for your country. But as I showed you, most of the prediction models would have the same results when they recalibrated for your country based on your local information. I think there is no difference between global risk or WHO risk score or score2 and so on when they could recalibrate it correctly for your country. If you can recalibrate these models for your country, all would be the same and resulted in the same risk charts. But some of them have some risk factors that their measurement is so difficult or expensive. For example, pooled equation model uses HDL cholesterol, and measuring HDL cholesterol in remote areas and in rural areas and areas that doesn't have enough facilities is a problem. So maybe using WHO risk score that uses simple risk factors is better than the others. And also global risk. But global risk is a complex model. You know, recalibrating the global risk is not easy. But recalibration of WHO risk score is better. And actually WHO recalibrated it, its model for different areas, and maybe you can use the WHO risk score for your country.
Okay, thank you very much.
Okay, you're welcome.
Thank you very much. So, very interesting lectures, open our horizon and give us insight about how to develop. So maybe rather than developing a new prediction model. It's more easier, not just like to recalibrate the WHO, the already established prediction model using our own data set. So we hope later on maybe we can discuss also about this recalibration. Hopefully we can collaborate with you as well, the food in the future. We will. I'll send you an email about the next meeting we can discuss. So if any
it's my pleasure.
If any other attendant on the meeting, you can also send an email to our cluster NMPA if you want to collaborate as well. Just let us know so you can be involved in the collaborations in the future. Thanks again.
I will be in your service.
Yeah. Thank you very much for your very insightful presentations. I hope we can also have another meeting in the future as well.
Sure. Yeah. Thank you so much again for having me in this lecture.
Okay, thank you very much, and I'll see you. Bye.
See you. Bye-bye.
For all the attendees of the meeting, hopefully it will also useful for you as well. Bye, and
bye-bye.
close the session.
Bye-bye, everyone.
Next meeting. Bye.